All right, welcome. This is Optometric Education Consultants. We're doing our Tuesday webinar. Tonight's topic is glaucoma gauntlet, managing the challenging cases. I will be presenting along with Greg. When you have questions, please put them in the chat. We will pause periodically to discuss them. And we will have a lot of interactive discussion between Greg and I. If you have questions, please put them in at the appropriate times. We'll stop and we'll answer your questions to make sure that we stay interactive and engaging as per COPE requirements. Greg, is there anything you want to add?
No, thank you. Perfect. Thanks.
Okay. My disclosures, I've been on a consultant or advisory board or speakers bureau for Novartis, Allergan, Glaukos, Zeiss, Area, Ocular Therapeutics, and Bausch & Lomb. But I've got no financial interest in any products we may be talking about tonight. If we discuss any sort of instrumentation or medication, it is only because that is what we use, and we're not implying any brand superiority or inferiority, right?
Yep. I'm going to discuss many products and instruments tonight. I have no financial interest in any of these products or companies. No superiority claims out here. The list of mine, we need to update, Joe, make sure we use the current one, is a lot longer than what's listed there, but it goes from Alcon to Allergan down to Dompe to Sun to OptiView. And then the same thing with the advisory boards. And I do sit as the PA medical director for Involve, which is a managed Medicaid. And I am half owner.
And apologies, I was looking for that and I pulled this out off our last webinar and I thought this was the updated one.
All right, no worries. Yep. No worries. Just want to make sure everything's properly disclosed.
Okay. Well, this is managing challenging cases, and we're going to be talking cases. We're going to be sharing opinions and sharing cases. But I think some of the best education comes from friends talking to friends or colleagues talking about to colleagues, saying, "Hey, I saw an interesting case," or "I've got an interesting case. Can you give me some advice on this?" So this will be all case based, and they're somewhat challenging cases. But they can be challenging for a number of reasons. They can be challenging for management. They can be challenging for personality issues. Or it can be challenging in terms of diagnosis. And the first one I want to talk about is a case called It Just Isn't Clear. She's a 24-year-old female who is a really good historian because she came in and she complains of blurred vision in her left eye, which happens twice a year since she was about 7 years old. It would last a few days and it would go away on its own. She would improve and never sought medical care until now, which I think is pretty remarkable history. And that history is what immediately clued me into what was going on. Now, how did I meet her? This is when I was still at the university, and a student and resident had been refracting the hell out of this woman for about 30 minutes. And they were going back and forth between +1/4 and +1/2. Now, she was 2015 in her 2020 in her left eye, but she's 2015 in the other eye. And comparing, she said, it just isn't clear. She just wasn't satisfied. You know, going +1/4, +1/2, they couldn't get her happy. And that's when they came to see me. And when I listened to that history, I really had a strong suspicion. This is my Dr. House moment as to what was going on. They tell me that medical history is unremarkable. Computation and entering tests are all unremarkable. And without telling them why, I just said, go back and assess the anterior chamber of that eye. And they scurry off and they're gone so long, I forget they're there. And after about 25 minutes later, they come back and they say to me, we can't judge the anterior chamber very well because the cornea is too cloudy. And at that point, I knew virtually for certain what this condition was. So I go to meet this young woman. She's in no distress. You know, she is noticing some blurred vision in her left eye, still at 2020. Conjunctiva was clear. She had corneal edema and keratoc precipitates on the endothelium. The chamber was deep, and her pressure was 21 in the right eye and 70 in the left. So, Greg, what are your thoughts here?
Well, What you said the anterior chamber?
Besides the right eye being hypotenuse.
Yeah, the right eye's a little low, isn't it?
Mhm.
You have deep as the anterior chamber there. Is there
Mhm.
anything else that we need to? Oh, you have KPs. I see it up there now on the
Yeah,
cornea.
and I will have to admit, I really couldn't assess the chamber reaction. If there was anything, it really was very minimal.
Yeah. I mean, we're kind of going along the lines here. If we're talking cell and flare, deep, a pressure like this, and really not much pain, we're going to be thinking along Posner-Schlossman type
So
of.
why don't we
Of
hit polling question number one?
all right,
Greg, do you recognize this area?
I do recognize that area.
That is Scottsdale, Arizona. So what's the most likely diagnosis? Is it angle closure? Is it a Posner-Schlossman? Is it an open angle glaucoma? Is it steroid-induced glaucoma? Is it some weird systemically induced glaucoma I learned in school but can't remember now? Or I don't know. And I don't know is a viable answer because that's why we're here, to learn.
Did you take that picture, Joe?
I think I did, yes.
That's pretty good. You got the flame and everything going there.
I fancy myself an artist. Looks like we're scrolling through pretty quickly. So we have angle closure, Posner-Schlossman, open angle glaucoma, steroid glaucoma, something weird I can't remember. I know I heard somewhere, or I just don't know. And I said that's a good answer because that's why we're here. We're here to learn. So what do you think, Greg? Want to call it there?
Yep,
You seem to
I'll
be
end
slowing
it.
down.
I'll share it. And 64% going with Posner-Schlossman. We got angle closure, few primary open angle glaucoma, steroid induced. I like the steroid induced thought. Something weird, and I don't know.
Now, the thing about angle closure is the relative lack of symptoms. And we have to consider that. And I think that what we're going to lean toward is this is the case of Posner-Schlossman syndrome for glaucoma cyclitic crisis. Now, the odd thing I find about these names is usually if a condition has two names associated with it, at least one of those names would be easy to say or spell, but neither of these are easy to say or spell. Glaucoma cyclitic crisis, or GCC, or Posner-Schlossman syndrome. That's what we're dealing with. And this is actually another patient who had a similar condition, albeit the pressure is only about 35. And we had a number of these centrally located keratotic precipitates, and that's one of the hallmarks of this disease. The anterior chamber reaction is not very heavy at all. There's not much to it. Now, it has been said that this is a trabeculitis. And I want to shed a little bit of light on this. It has been said, but it's never been proven. We don't know that. It's surmised that most of the inflammation is located in the trabecular meshwork because it's not a heavy uveitis. And the pressure rise is really very, very high. So it's theorized, but it's never been proven. But people call it an acute trabeculitis. I call this idiopathic and idiosyncratic. Now, talking about the idiopathic part, well, I'm not sure it's so idiopathic. It behaves an awful lot like a virus. And once it behaves an awful lot like a virus, it's unilateral, it's recurrent, it is self-limiting. It tends to burn itself out over time. Now, there have been aqueous taps in these patients. They've actually found herpes virus and cytomegalovirus. They've also found no virus in the anterior chamber of these patients. So is it viral? I think it's a strong possibility. We also have something called herpetic keratoid uveitis, where we have mild inflammation and a disproportionate pressure rise. Not quite as high as what we see here, but it's there. And I think they're probably different ends of the spectrum of the same disease process. Whereas in herpetic keratoid uveitis, they have no pre-existing herpetic disease. Now, these do respond very well to steroids. They are often recurrent, and when they're recurrent, the interesting thing is they are very similar. It's not like a person who's going to have a pressure of 30 one time and 50 on another time, and then for whenever I see these patients recur, I know what the diagnosis is. It's very, very straightforward, very simple at that point. They almost always are within 2 millimeters of their previous pressure, meaning they spike to 55, they're going to be in the mid 50s when they recur. This is fairly straightforward. Far more common than people realize. A lot of times we just overlook this disease. We don't think about it. Greg, do you have any clinical pearls here or your approach to a condition like this?
Yeah, nothing that I would add at this time, Joe. As we go through the case, there might be a few things, within treatment that I would add. I think maybe it might be good, why, if you want to explain why with a pressure of 70, why aren't they in pain?
That's part of the idiosyncratic part. We don't know. Why are they symptomatic at all? My experience, and I've seen a fair number of these patients. They might get a bit of a red eye. People who are not pain tolerant, they may have a bit more discomfort. And there's probably a bit of a range in presentations. But a person with acute angle closure, they're going to have nausea, they're going to have vomiting, they're going to have very poor vision, a fixed mid-dilated pupil. None of these things happen here. So, Greg, we don't really have a good explanation. The reason she has any symptoms at all is the pressure 70 shuts down the sodium potassium pump in the endothelium and it becomes edematous. Now, when that happens in acute angle closure, those patients are nauseous. These patients really are hardly even bothered.
And it goes back to, you hear speakers all the time saying, well, this is the reason why. And I think a lot of it's hypothesis, never really been proven, as Joe mentioned. And, I think the slow onset, maybe the inflammatory, the slow rise in pressure. But also we talked a little bit about herpes and, herpes is that, fifth cranial nerve and it causes a decreased sensitivity. So, these are all things that, you can think about that's happening, but are those the true reasons why? But going back, it helps differentiate between that angle closure versus a Posner-Schlossman. We had a comment in here, Joe, that someone's feeding off of what you said, had a patient like that, got it every spring and IOP was always 45. So
yeah, it is very stereotypical. I mean, they all they come back to the same pressure. If it's 55, it's going to be 55 plus or minus 2. That's right, what I've seen. And we know what it is. They know what it is. And the diagnosis and treatment is really pretty straightforward for down these patients. They're not hard at all. Now, number one, steroid. This is what you need. And there are patients I've had where more mild pressure elevation, like only treated with steroid. Any of the aqueous suppressants should be fine. I'd probably stay away from miotics, and that can possibly worsen things. Prostaglandin analogs are not likely to help much, but they're certainly not likely to hurt either. I don't know how I feel about rho kinase inhibitors. If this is truly a trabeculitis, and we don't know, anything that enhances trabecular outflow probably will be less effective. So I'm not sure how I feel about rho kinase inhibitors. I'm very lukewarm about prostaglandins. Many of the aqueous suppressants will work very well, and of course, a steroid. I'm not very bullish about cycloplegia. I think that a cycloplegic in a situation like this, as opposed to a true raging uveitis, is going to bother them visually more than the disease itself. So I usually stay away from cycloplegia, but you're not wrong to do it. Now, I'm not yes.
Yeah, I was just going to say, so my pearls on that when we talk about treatment is, definitely want to hit them hard with a steroid. And Joe has it there in office, Pred Forte. And, I have no problem going, every 1 hour, 2 hours, because really that's the inflammatory part that's kind of driving up this pressure. But in a sense here, when we has the treatment slide up here, what I like to do is I'll do Combigan QID in that eye. And every time I say that at the audience looks at me and goes, oh my gosh, he's taking a beta blocker and using it 4 times a day. Well, remember guys, I'm only using it in the one eye. And if I prescribe Combigam BIDOU, I'm still using 4 drops, right? I'm just doing one in one eye, one in the other, 1, 2, and then at night, 1, 2. That's a total of 4 drops. So one of my favorite things I like to do when treating a condition like this is to use Combigam. It's got 2 medications in it. It works well. They're fast acting in a sense with the Alphagan, and using a QID with the Predforte. And I usually can manage them pretty well. And that's just another pearl that I like to point out with that Combigam is that when you do have those unilateral spikes, you can get away with that using that drop 3 or 4 times a day because you're only using it in one eye.
Yeah, a good steroid. Now, people ask, what about Durezol? Durezol's great medicine, and it's probably the steroid most likely to have a sample of. I would use that maybe 3 times a day, no more than 4 times a day. Predforte is not quite as efficacious as a Durezol, but it works fine. So what I did in this patient was a timolol, Alphagan, and Trusop, separated by a couple minutes. Maybe 5 minutes might be a little bit of an exaggeration. And I'm not one to lower pressure in the office. I did this mostly as an exercise for the students and residents. And after about 30 minutes, the pressure dropped down to 50, and her edema completely cleared. Vision went right back to 2050. This is perfect. Can I go now? No, not quite. So I gave her another regimen. And after about another 30 minutes, she was down to a pressure of 35. And I certainly safe to let her go. I sent her home with an Alphagan and a Predforte. And I guess, Greg, the only reason I didn't send her really Combigam is I probably didn't have a sample at that time.
Right, exactly. Yep.
Comes back, next day and follow up, pressure's 10. OCT, fields, everything's perfectly fine. So here's a young woman who's been spiking to 70. How do I know she spikes to 70? Well, because the pressure 50, she doesn't have any complaints. Twice a year for several years. Everything's fine. And that happens with a lot of these patients. They can walk off 1 or 2 of these attacks. But when people start to get recurrent disease and they have 3 or 4 attacks a year and they're spiking, they will develop damage. I would say 50% of the patients with this disease that I've seen who are recurrent, they develop glaucomas damage. So is it truly benign? Not really. I mean, it's a lot less severe given the pressure rise at that time, but the longer they spend in spikes, they will develop glaucomas damage, and I've absolutely seen it. Is it real, or is it? I see someone raise their hand. Put everything in the chat box, please. We can't unmute people. Is it real, or is it a variant? Have you been? I think it's separate. It's a ubic glaucoma, right? I think it's separate. And is it a herpetic variant? I do think so. Okay, I think that it is a herpetic variant. I've actually put these patients prophylactically on antivirals, acyclovir, 400 milligrams twice a day, just like in the HEAD study. And I do this with full disclosure about my reason for doing it and the lack of support. Ganciclovir has been shown to be effective, but not, I don't think acyclovir, but I've done it, and I believe that I have lessened the attacks from a number of people. Greg, any final thoughts here?
Yeah, I'll feed off of your, going with, 400 milligrams acyclovir twice a day or 500 milligrams of Valtrex if you want to go that route once a day. I think maybe if you want to feel a little bit more comfortable doing that, I would ask the patient, hey, are you a cold sore sufferer? Do you get on your lip or ulcers in your nose? This is, potentially something that's trying to erupt in your eye, and that's what's causing that. If you want to kind of maybe feel a little bit more, because I have done what Joe's done and placed these patients, not all of them, but the ones that keep recurring and the ones that are cold sore sufferers, and it has either eradicated or minimized the attack. So that's just another little question that you could ask in the office. We had a comment come in, Joe. It says, would you consider Fuchs heterochromic cyclitis? I think that's a great differential on this.
The answer is we should consider it more often, because I think this is probably a very missed disease and very missed cause of uveitis. Now, in this case, I wouldn't equate them, because in Fuchs heterochromic uveitis, The anterior chamber reaction is a little heavier than we see for GCC, and the pressure rise is not quite as high. They get an open angle glaucoma. They get cataract. The heterochromia may be subtle, to be very easily missed, and they don't really respond to steroids. That's the challenge, and I think we need to consider this when we have recalcitrant uveitis, to think that it could be a non-responsive condition such as Fuchs. But Fuchs tends to be a little bit more modest in the pressure elevation, maybe in the 30s. Anything else, Ray?
Another one came in. Could you use Lotamax? And I think,
Absolutely.
yep, I think the answer to that is true.
Yeah. You could probably use fluoromethanol. It may take a little longer to go away, and it may not go away any faster than it would on its own accord if you use a weaker steroid. Oh yeah, Lotamax would be absolutely fine.
Another question rolled in regarding if the patient's taken atenolol 50 milligrams, orally, would you still use the Convigan aid? And it's hard to really answer everything with a broad brush. My quick answer would be yes. However, if the patient, this is a 24-year-old patient in this case. Now, this one's saying, taking atenolol, if the patient is brittle, asthmatic, all these other things that we can paint a bad picture for. No, and maybe go some Brinza, and you can do some Brinza QID on that one if you wanted to go that route. Am I worried about slowing? You can check pulse, you can check the heart rate, as we should. But am I really worried about that when someone's on a beta blocker? My concern is really not stopping the heart or the heart rate. It's really the effectiveness. They're already on a beta blocker. Are they going to be able to block any more beta when it comes down to that? So, those are some of the comments that are out there. Am I worried about killing him at 4 drops and adding to the atenolol? My quick answer is no, but we're going to be cautious with that. And we're going to really assess the patient to make sure that we're going to do the right thing.
I agree, Greg. There have been numerous occasions where I've needed a beta blocker in a person who was already on an oral beta blocker. And my approach is, when in doubt, contact the primary care physician. And the way I usually do is I write this. I used to write the script and say, show this to your primary care physician before you fill it. And I can't think of a single instance where a PCP has declined.
Right. And where I've been shocked is you just didn't get the effect that you were looking for. So.
Yeah. Well, here's a case. He's a 31-year-old male, and I think that the issue here will not come in the diagnosis. It'll be fairly straightforward. It's going to be a very debatable management. 31-year-old male, medical history unremarkable at that time. Maybe his grandfather had glaucoma. He's not entirely sure. His pressure is 32 and 30. He's got very average pachymetry. Gonioscopy, he's open and normal. And here are his optic nerves. Greg, why don't you share your thoughts on those nerves?
Well, quickly, they look pretty darn good. I like looking at the isn't rule, where the inferior is thicker than superior than nasal and temporal. The color looks good. Looking at the nerve fiber layer from kind of zoomed in, I don't see really any nerve fiber layer dropout. I'm concentrating on the right eye right now. Looking for any types of Drance hemorrhages, not really seeing anything, and they could be missed. So I keep going around, seeing what you're throwing in here tonight, Joe. Looking at now the left eye, the inferior looks good, superior nasal temporal. Nice and healthy, not really seeing any notching, no hemorrhaging, and the nerve fiber layer looks pretty good. So I'm liking the nerves.
I think they look terrific. Any comments on the visual field? It should be pretty straight. I think this is pretty straightforward.
Yeah, that looks pretty good.
Greg, looks like it's time for a polling question. Does this look familiar to you?
It does look familiar to me. That looks like Mall of America there.
That is. So how should this patient be managed? I think the diagnosis is pretty straightforward. It's ocular hypertension. Should we do pressure reduction with a PGA or similar medicine? Close observation without medical treatment, or don't know.
Joe, go back to the original, to the case here, just while you have the polling question. Just want to see the history. All right. Perfect. Thank you.
So 31-year-old male, weak family history, pressure in the low 30s, average pachymetry, nothing funky, no secondary glaucoma. Great looking nerves, full visual field. And by the way, the nerve fiber layer assessment is also very normal. Okay, I think we're getting close here. So how should this patient have been? It's clearly not hypertensive. There's no glaucoma here, but there is risk factor for glaucoma. Do we treat the patient medically? Do we observe them without medicine? Or I'm not sure what I want to do.
And I think we had a good comment come in that we might want to address when we're done with this case, Joe.
Okay.
April has, how long do you treat them for just until the symptoms are gone? And we probably should kind of go through how, it's, the treatment and follow up for that giant cell, giant cell arteries. How about glaucoma cyclitic crisis? All right, I'm going to end the poll. Going to share the results, and I'll let you go through the results.
Medical pressure reduction, about 39%. The majority say they're going to observe without medical treatment. A few people aren't really sure what they want to do. I'm going to step back and answer that question about glaucoma cyclitic crisis. How long do I treat them for with steroids? I'm generally done within about 2 weeks. It's just a very, very responsive type of condition. So 2 weeks, maybe a week with a short week taper is all. Greg, what would you do in this patient? Are you gonna treat him, or are you gonna watch him?
I'm going to observe.
Okay. If we wanted to treat him,
because observation is a treatment.
Indeed, it is. Now, if you want to therapeutically reduce pressure, is this the person you recommend for SLT, or would you go medical therapy?
Ooh, if we're going to lower the pressure, 31-year-old SLT this early. If the patient really wanted it, I would probably, if we're going to lower pressure, I'd probably go something topical.
Okay, because SLT before the 40, we've probably done it once already, and we're out. I mean, we're tapping out there.
Yeah, I think because the discussion is, I think where we could go with this. You talked about two guys sitting around, BSing about glaucoma. Is, they tout it as you can do it as many times as you want. And what's your thoughts on that?
My thoughts are you can probably do the entire angle twice.
Yeah, and I agree.
I remember doing a program with one Steve Getty, who is an internationally renowned glaucoma specialist out of Bascom Palmer, and his name's going to come in just a moment. He was doing a presentation for me, and he was talking about SLT, and I remember how he fastidiously said, it's theoretically repeatable. Every time he said theoretically repeatable. So he was very, very, very cautious about saying let's do it again and again. Now here's a challenge. Diagnosis is straightforward. Treatment is a challenge here. What's the best thing to do? What are the long-term implications? Well, here's a 31-year-old who probably has a very healthy vascular system. Maybe unbeknownst to us, he wouldn't start developing damage until he was, 47 years old. So anything between 31 and 47 is unnecessary treatment. Now, is that something we can know? No, we don't know. We're making an assumption he's got a good and healthy vascular system and that he can withstand the pressure. But we just don't know. That's why we observe them and we treat them with observation and we follow them over a period of time. Now, what are the long-term implications? Well, we went through a period a few years ago saying early diagnosis, get them diagnosed sooner, because if you do, that's less time for them to run into trouble. You can argue someone this young has so long to get in trouble, lose vision. We have to be careful of that. Well, we don't know that he's going to lose vision. Now, the flip side is everything that we use is going to have some sort of implication. Ocular surface disease, tachyphylaxis, over years, every medicine we use will probably wear out or loses efficacy, and SLT is relatively ephemeral. Now, I presented this to two internationally renowned glaucoma specialists, Rich Parrish and Steve Getty out of Aspen Palmer. I said, what would you do? One person said, I'd absolutely treat him. The other said, I'd absolutely not treat him. So nobody's is gonna really agree on a situation like that. Greg, you observe him. I actually wanted to treat him. So we had a discussion and we looked at the risk and benefit, and he agreed to a therapeutic pressure reduction. So with one medicine, a prostaglandin analog, his pressure came down from the low 30s to the mid-teens. And from then on, in the 15 or 18 years that I followed him, not a darn thing happened. His nerves didn't change, his feels didn't change, his OCT didn't change, his pressure didn't change. In fact, he became what I call bored. My hair got a little grayer, his hair got a little bit less present. We grew old together. Nothing changed. Now, I can possibly even argue that if I did nothing, he might look the same. I can't tell. Greg, any thoughts there?
Yeah, a couple have rolled in here to the chat, and one is need packs to see true IOP, and let's comment on that, or let's discuss that.
Well, his packs were average 560.
Right. So that's why when we went back, I wanted to kind of see where the packs were. 556 and 560, right? And let's address that for the audience right now. Joe knows that this is my big soapbox, and it goes back to when the ocular hypertensive treatment study came out, whenever that was, 2002, 2003, and pachymeters came out, and they handed out all those cards that said if it's this thick, adjust up, or it's this thick, adjust down. Everyone out there, please kind of pay attention to this. If you're adjusting IOPs up and down based on packs, that cornea is way too complex to try to adjust the IOP up and down based on one reading. Cornea thickness, right? Don't forget, there's all kinds of cornea properties. I'm going to touch on corneal curvature, right? And there's cornea rigidity. And probably cornea rigidity is probably what influences the Goldman tonometer, if we're talking Goldman tonometry, the most. And it has been proven numerous times that you can have a really thin cornea, but the rigidity is high. So it's a thin but rigid cornea. And whenever you are doing pachymetry and you say you have a 600 cornea, you're making one big assumption that a 600 cornea is rigid. And it's been proven multiple times that a 600 cornea could be rather mushy. And you're making an assumption that a thin cornea is going to be mushy. And it's been proven that a 500 cornea is rigid. So you are potentially adjusting the wrong way. So really, I think what it has shaken down to, and we can go to the ocular hypertensive treatment study. Remember, it was 555 and 588. I pretty much use 500 and 600 in clinic. If it's 500-ish or less, it increases the risk. And if it's 600 or around 600 or more, it decreases the risk. And if it's somewhere in between, then really, I don't put it in as adding risk. But the whole point of that is do not adjust IOPs up and down. The other thing that I'll get when I do that, and people will come up afterwards, or we're doing live conferences, and they'll go, well, the ophthalmologist is adjusting them up and down. Okay, well, that's not, correct either. Just because they're doing it doesn't make it right. So just don't adjust your pressures up and down. Now, another thing that I have really relied on over the last year in our practice is we have the ocular response analyzer, which gives us cornea hysteresis. And it really wasn't in the history, but if the patient had a lower cornea hysteresis, let's say around the 7, that might cause me to pull that trigger on treating rather than observing. If they had a normal cornea hysteresis, then like 10.5, then I might sit on that in the observation. So cornea hysteresis is the body's ability, or hysteresis is the body's ability, or anything's ability, like struts on a car, to dampen energy. And if the patient had a higher cornea hysteresis, 31, it tells me that the eye is capable of handling that, as opposed to a more fragile eye around a 7. So cornea hysteresis has really become a part of my regimen. And someone did drop in here about cornea hysteresis of value for future risk factor, and the answer to that is yes. And then, is anyone using the new CATT tonometer? So I'm not sure what is the CATT, Joe. Do you know that one?
No, I'm not using that at this time.
So I'm not familiar with what the sorry, Chris, on that one.
That was a great summary of those risk factors. You know, Greg, if this person was under 500, I would certainly advocate treatment. If they're over 600, I probably would not. He was very much average. But you know, we made the decision. He made an informed decision, and we talked about risk and benefits and accepted the treatment. And it got to a point where I saw him once a year. I did the photos, the OCT, the visual field, all at one time a year. He was very boring. Nothing ever changed.
Another question rolled in:
Okay.
the effect of extended contact lens wearing with cornea swelling on cornea thickness. Yeah, you know, someone that's sleeping in a lens, you know, they're going to create hypoxia. There's probably going to a few microns. I'm not sure. There's probably some study out there, the effects of cornea thickness. You know, obviously, you know, if you really want to get into treating this patient, you can ask them maybe not to wear their contact lenses to find out what their true cornea thickness is. But again, is it going to shift that much? Is it going to be 100 microns? Probably not. So, you know, if someone came in and they were 520, okay, maybe they're closer to 500 or 515, you know, somewhere in that range. They're still at the low end. You know, if they come in at, you know, 575, they're kind of at the higher end, maybe in the middle. So, I mean, that's, you know, yes, it can influence it, but, again, that goes to another reason why not to adjust pressures up and down. All right, Chris rolled in here. He says, sorry, CATS tonometer, supposed to take cornea biomechanics into consideration. Yeah, I think I know which one we're talking about there. It actually sits on the eye and it tries to, let's talk about tonometry, guys. So if you think about what Goldman is transcorneal pressure, right? You're going through the cornea. So it's not a true IOP. That's why we don't want to take an imperfect measurement and try and make it more imperfect by inducing human error. So Goldman tonometry is not like true IOP, putting a sensor in the eye and figuring out what the IOP is. It's just transcornea. So these newer tonometers out there, yeah, they all have some kind of, you know, in a sense, trying to get that true IOP. I can tell you right now, I had to kind of adjust a little bit with my aura, because it gives you a Goldman reading, it gives you a calculated reading. And I really like that, to be able to do that. But it doesn't mean you always have to do glaucoma with Goldman. It's just whatever you're using, just make sure you're, in a sense, consistent, but more importantly, truly understand what you're interpreting. Kind of like when you have a visual field, make sure you know that what you're interpreting. When you have an OCT, try to, you know, learn what you're interpreting. When you have that new tonometer, just try to really understand all the ins and outs of that tonometer.
All right.
Okay, Joe, I think I'm good.
All right, and here's a case. I think when we look at a glaucoma patient, we all make an initial assessment. Either we're overt about it or we're subvert about it. We think about it. We think, you know, what is the prognosis for this patient? And there's many things that goes into that. We don't have a one sentence answer for that, but we always get the sense of what we think is going to happen. And here's a case that for every aspect really should have a bad prognosis. She was an older female whose initial baseline pressures were actually in the low 20s, but I would tell you they will go much higher later on. Average pachymetry, goniometry is open, but she's got exfoliation. And, you know, she's got enough exfoliated material to, you know, in each lens to stuff it filth. So she clearly had exfoliative glaucoma. And for those that don't see this often, I will tell you, this is one of the and ophthalmology will agree, this is one of the worst open angle glaucomas that you're ever going to encounter. One of the worst chronic open angle glaucomas. These are people who usually have higher pressures. Natural history studies have shown the pressures do go up consistently over time. They need more medicines. They need laser. They need surgery. They're more likely to become visually disabled and more likely to progress, even with a similar pressure reduction to primary open angle glaucoma. There's just a lot of bad stuff that happens with exfoliation syndrome. Now we take a look. She's got cataracts. She wears RGP lenses. She's really thrilled with her RGP lenses. She had a very light fundus cataract. Now, she's mildly damaged to the optic nerve. She has some superior arcuate defects in each eye, and these are all reproducible. And she has relatively mild disease from a glaucoma standpoint, but she's got a very bad secondary condition called exfoliation syndrome.
I like how that visual field blind spot kind of matches that atrophy that's around that nerve too.
Yeah. So she's diagnosed with exfoliated glaucoma. This is very, very clear. This is relatively incontrovertible. And she's got modestly elevated pressures. Now, here are some considerations. She's got mild field loss. She is older. Her baseline pressure is lower, but she has exfoliative material. She's got exfoliated glaucoma. So can this patient be monitored or should she be treated? And this is a situation where I'm always going to advocate you do something. This is a bad disease that can get bad fast. So I initiated, or we had a discussion, she understood, and we initiated pressure reduction medically. And before we go any further, I want to preface by saying she is uninterested in cataract surgery. She's uninterested in laser. And I'll be honest with you, she was actually very uninterested in medicine.
Hey, Joe, can you just go back a second?
Yeah.
And then go ahead and finish your thought, because then
How far back?
No, right there. That's it.
Okay. So I prescribed a prostaglandin analog, and I sampled her. She calls me the next day, and she read the product insert. She was actually more concerned about the adverse effects of prostaglandins that she saw on that product insert than she was about going blind from glaucoma. And she wants to see change or other conclusive proof that she needs treatment. She says that I believe you, I have glaucoma. Will I go blind overnight? And of course, that answer is no. She said, well, what if you follow me for a period of time? If nothing gets worse, I won't be bothered. And if things do get worse, we can talk about doing something. And that's actually an informed decision. She made the decision. Now, I disagreed with it. I advocated treatment because everything tells me she's going to do poorly. I will tell you, she ultimately gets up to a peak pressure of 34 and 37. That is her peak. Greg, that brings me to polling question number 3. Do you recognize this area?
I do recognize that area, but I'll let you disclose that area.
Out to beach or Florida? Out to be the beach. So how should this patient be treated? Medical pressure reduction, laser pressure reduction, surgical pressure reduction, close observation with no therapeutic intervention, or I don't know. Or I'm not sure.
Joe, while this is rolling in, can we just have this discussion in a sense? First patient that we talked about was ocular hypertension. And I think that it's clear that you don't have to treat. You can treat if you want, because the ocular hypertension treatment study did give us risk factors. But someone comes in at their ocular hypertensive, you don't have to treat or recommend treatment. Is that correct? And then, because you're kind of the medical errors jurisprudence guy, but then in this case here, you said, can this patient be monitored that has glaucoma? My feeling is, okay, we know she has glaucoma because there's damage. We can recommend treatment, but they don't always have to do it. So is the key here, like, okay, glaucoma, yes, you should do something because we know that glaucoma has damage and we want to stop it and we should recommend it. And if they opt out, that's fine. But when an ocular hypertensive comes in, we don't really have to recommend treatment, or do we have to, I guess?
We can advocate treatment in ocular hypertension if we think that there's a risk of progression. And we can allow the patient to make the decision. Ultimately, patients always make the decisions.
Right.
We can argue that in glaucoma, we should advocate treatment, but in the early manifest glaucoma trial, actually, this is exactly the kind of person that would have been in this study, the early manifest glaucoma trial, because she had early disease, she had mild disease, and she had exfoliative disease. These were patients who were in this study. And what they found is some people with early glaucoma don't get worse, or they don't get worse very fast. But ultimately, what they did find in the study was the patients who did get worse and got worse the fastest were the exfoliated patients. So it looks like, I think we can end our polling here, Greg, and share our results. The majority say medical pressure reduction, okay, laser pressure reduction, surgical pressure reduction. Some people want to observe, and some people are not sure. Now, I will tell you, she was not interested in laser. She was not interested in cataract removal. She had RGP lenses that she was happy with. She certainly was not interested in medical pressure reduction. So that left us with the option of following her over time because she would not accept any therapeutic intervention. Now, this is actually what happened over a period of about 10 years of following her. What I want to point out is, yeah, she's got glaucoma, and over the course of about 10 years, nothing really changed. Now, this is a person who went into the upper 20s, low, and sometimes even high 30s. She did no therapeutic pressure reduction. And over the course of 5 years, she lost only a few percentage points to her visual field. And the rate of progression by the guided progression analysis shows us she might lose another 5% of vision in the next 5 years. And at that point, she'll be in her early 90s. So we've gone from her late 70s to her late 80s. And if we keep this trend, her early 90s will show virtually no pressure, no visual field change or risk of visual disability. So she's changing at maybe a 0.3 to maybe a 0.5 per year. And this was somewhat surprising because she was right and I was wrong because I wanted to treat her immediately. And if she had used treatment at that time, she probably looked the exact same. I would have felt good that I successfully treated her, and she actually successfully treated herself better by doing nothing. Now, I don't advocate watching glaucoma in most cases. I don't advocate certainly watching exfoliated glaucoma. But I will tell you, when we got about year 7 or 8 into this, and she was a good patient. She came back 4 times a year, allowed me to do fields, allowed me to do, photos, dilation. She's always good about that. After about 7 years or so and no changing, I just stopped advocating treatment. She'd come in, her pressure might be 28, and she said, "Is that good?" And I said, "Apparently for you it is." So she has risk factors. She has exfoliation, high pressure, older age, no progression. Now, one day she came in and she had a new concern. She noticed that her eyelashes were somewhat thin and thready, and she heard there was a medicine that can make her eyelashes thicker. So she won't use Lumigan, but she'll use Latisse. Or putting it another way, she won't use Bimatoprost, but she'll use Bimatoprost. I thought I could talk her into it, but she ultimately did not go through this either. Now, what was the final outcome? I was updating this lecture a few years ago, and I looked and I saw I was missing the most recent visual field. I saw she had missed her last appointment with me, so I called my front desk, and I said, she's missed an appointment. Please call and get her back in the schedule. And a few minutes later, my front desk called, and they told me her number's been disconnected. So I'm not sure if you do the same thing, Greg, but my initial reaction to the situation that is, I Googled her name. The first thing came up was a link to her obituary. She died of natural causes about 2 months after my last exam with her. She was about 89 years old. She had a very serious disease that she was not bothered by and was not treated for. So the answer is we just don't know. And that's why we have to follow patients. Greg, do you have any thoughts here?
No, other than, the pseudo exfoliation, is really shocking there that it didn't go down that path. I think of maybe the 4 patients in 2020 that I ended up sending for surgery, either some type of valve procedure, express shunt trab, something along that line. And probably, if I'm just sitting here thinking, probably all 4 are pseudo exfoliation. So great for her that she was able to overcome this nasty secondary type of glaucoma.
Yeah, I mean, she was right. I was wrong. She didn't do any therapeutic pressure intervention, and she was never bothered by the disease. But again, I don't advocate this as our approach. What I'm saying is, we just don't know. We do our best estimations, but sometimes patients will surprise us.
If she would have elected cataract surgery, I would have been really careful in the surgeon that I would have picked, in the fact that those zonules would be extremely weak. I'd send it to maybe a surgeon that doesn't do ECP, as one of their, cataract surgeons love to do ECP, to get that kind of that added cost to get those pressures down. And they have to turn the laser up on the ECP so high that to try and get a laser take. So I guess my final thoughts on that would be, if she eventually ever would have elected cataract surgery, just on a bunch of things, but just the weak zonules, you want to make sure that surgeon, wasn't, maybe a newer surgeon or a resident that was out that didn't maybe have the hands, and you'd be fishing that lens or sending them to retina to get that lens out of the vitreous. Or, again, be careful with ECP on pseudo exfoliation, because then you'll be dealing with a really high pressure the next day.
Now, if anybody has any questions, don't raise a hand. Put it in the chat. We will address anything in the chat there, Greg.
Just was a direct message. I'm just not sure which case they were referring to. It says, what is your opinion on MIGS procedure for this? And I'm guessing it would have been the case before, but I'm not sure. So,
well, the case before was an ocular hypertensive. The person that really had cataract. A person like this, MIGS procedure, probably not a very good option, because that exoid material is like Velcro. And I think that could very easily stop up a stent. Now, maybe another MIGS procedure would be an option, but generally, these are patients that may actually need the full glaucoma surgery. Well, she's a 21-year-old female who's referred to me for elevated pressure, but did not bring her referral form. I don't, and she doesn't remember anything about that other than her pressure is high. Now, her concern is her vision is snowy. Those are her words, snowy vision for the last few months. It feels like it's getting worse. Now, medical ocular history is unremarkable. Family history unremarkable. She's an asthmatic who had been treated since about 2017 and has no medical allergies. She comes in, she's 20/70 in each eye, pinhole down only to 20/40. Pupils are unremarkable, cornea is clear, iris is normal, anterior chamber deep and quiet. Gonioscopy is open 360. There's no abnormalities in there, no pigment. She's only 21 years old. The Pachymetry is actually very much on the thicker side, about the 640 range. And this is what she looks like. And Greg, do you have any comments on these photos and these nerves and the retinas?
Going to the right eye, looks like maybe a wedge defect down there, Joe, inferiorly. That's about all. It's, it looks like that the draw me there was, that's where I like the stars. The inferior looked a little thinner than the superior. So the isn't looked violated. Then it looks like there's a little wedge defect. But then the superior looks okay. And jumping over to the left eye, I'm not really seeing much anything. So potentially something going on inferiorly there of the right eye.
I mean, if you look at the choroidal vessels here, you don't really see the choroidal vessels up here. And one potential reason is there's a large diffuse atrophy of the nerve fiber layer. And if we take a look now on the red free, I think we can see, I agree, there looks to be some relatively good diffuse atrophy there, but the nerves aren't overly impressive. Here is her OCT. We can see that inferiorly there are some abnormalities that are coming up as statistically significant and likely clinically significant. And we see there's some abnormalities on the ganglion cell complex. And we correlate this to her visual field. We can certainly see that she does have some superior arcuate loss. And one thing I didn't tell you, by the way, her pressure is 72 in each eye. And it was interesting that in the glaucoma service, the student came out and she said, I think the pressure is 72. And he said, I'm dubious, but it's glaucoma service and certainly is possible. And I checked myself and she was dead on at 72 in each eye. So we got a young woman who's got some visual symptoms. Corneas are clear, however, and her pressure is 72. And that brings me to our next polling question. And, Greg, do you recognize where we are here?
That looks like Mackinac Island, Michigan.
Indeed it is. So what's polling question number 4? What is the most likely diagnosis for this young woman? Is it angle closure? Is it Posner-Schlossman? Primary open-angle glaucoma, steroid-induced glaucoma, some weird systemically induced glaucoma I learned in school, but I can't remember now, and I don't know, which is a reasonable answer because that's why we're here to learn.
Joe, so the Biggs question was for the pseudoexfoliation patient.
Mm-hmm.
So when you answered that, so thank you. And then a question that's here, it says, with IOPs over 30 plus, any concerns of a central retinal vein occlusion?
The answer is no. You know, in the OAK study, they actually looked at the incidence of retinal vein occlusions in treated and untreated ocular hypertensives. And yeah, there was a difference where the untreated eyes had a higher proportion, but the difference was 2.6 versus 1.7. It really was not statistically significant. I will tell you, I've had patients in the 50s, 60s, and 70s never had a vein occlusion. Now, have my glaucoma patients ever had vein occlusions? Absolutely. They've all been in eyes that have been treated for glaucoma. So it's more, the more the issue is their comorbidities that have underlying diabetes and hypertension in both conditions, why that happens. But a pressure that high, you're not gonna stop up. Like I said, I've had patients with pressure 70s, and I've never seen a vein occlusion. I've seen vein occlusion in patients who have treated disease. All right, I think we can end this, Greg. So what is going on with this young woman? What's the most likely diagnosis? We have quite a few possibilities. Some weird systemically induced glaucoma I learned in school, but I can't remember. It got a few votes. Steroid induced is a little bit higher than primary open angle glaucoma, which would be very unusual in a 21-year-old. Not to say it doesn't happen, but it's relatively unusual. So, forgot to mention, looking at her, she actually had cataracts. That accounted for the snowy vision. And when I saw that and saw the patient, I knew what the diagnosis was. She had 2+ PSC cataracts in each eye, accounting for her snowy vision. Her pressure again was 72. And that's when I looked at her and I asked her, how are you treating that asthma? And find out that she is self-administering dexamethasone injections 2 to 3 times per week that she's getting online or through the mail from Honduras. She had used inhalers, which she felt were ineffective. The only thing she felt was effective was steroid, and she obtained them herself and was injecting herself several times a week. Now, I'm also going to share something that you all don't have here, and these are stock photos, but this is relatively what I was looking at as I sat back, saw PSC cataracts. She had a moon face. She was moon, her hair was somewhat thin. She had this fatty deposition on the back of, between her shoulders, the buffalo hump. I asked her partner and her if she had gained any weight. Her partner said, I didn't want to say anything, but yeah, she said, you've gained 40 pounds relatively quickly. So she actually had given herself a self-induced Cushing syndrome. So she was essentially almost, killing herself. Now, this is a situation where glaucoma can be fatal. She's using high dose steroids inappropriately. That's the genesis of the problem. We can't stop them. What I had to do is I actually had to keep her on steroids, refer her to an endocrinologist immediately, and the endocrinologist put her on steroids, put her on prednisone as a taper, because we can't shut down her adrenal glands or her adrenal cortical axis. She can't keep using it, but we had to taper her down on oral steroids. And oh yeah, by the way, she had diabetes as well.
And Joe, I think that's worth echoing, right? We are going to be like, oh my gosh, you created your cataracts. You have a pressure of 72. What do you mean you're buying the stuff online and injecting it? Look what you've done. And one of the worst things that you could do is the patient gets scared and they're losing vision, and have them stop their steroids, right? We have to be careful. It's worth echoing here. This patient needs to not, her adrenal glands are totally shut down. Our body needs steroids to be able to survive. And so her body's not producing them. She's getting them exogenous rather than endogenous. So we need to be careful that we don't scare her and have her stop all steroids, because then she'd be maybe in bad shape.
Now, of course, she was put on ultimately, all tolerable, topical medicines, and it really didn't do a heck of a lot to her pressure while she was still using steroids. So I was very disappointed by that. So ultimately, she referred out for surgery, and she had been lost to follow-up. I'm not really sure surgery had ever been done. I'm thinking that once she had gotten off the steroids, the topical therapies began to work a little bit better. But one shouldn't think that this is a stop a steroid and it will go back to normal. That isn't always true in steroid-induced glaucoma, especially something this high or this much that's being used, or this egregious. Stopping the steroid isn't always going to be the magic answer to lowering the pressure. Anything coming in, Greg? Or do you have any comments?
I don't have comments. That was well covered there, I believe. But a comment did come in, and it says, in your opinion, how long can a patient with healthy nerves tolerate IOPs in the 70s without severe vision loss?
Great question. The answer is, I don't know. I think it has to do with the patient. I think a 21-year-old is going to tolerate it a lot better than a 71-year-old. I don't think they'll tolerate it that well. What has been the most impressive that I've encountered in my career? I've encountered 2 ocular hypertensives. Patients, ocular hypertension, no nerve damage, no field damage, no nerve fiber layer damage, pressures in the 50s. And Greg, as you know, that's outside the range of the OAT study. There's no tactical precedent. We can't start looking at pachymetry and trying to decide, do we not treat a patient with pressure exceeding 50. But I have in my career had 2 patients with ocular hypertension in their 50s. Everything was still normal at that time. One person was in his late 20s. The other person was in his early 50s. Any other questions come in or comments, Greg?
Nope, that's it.
Okay.
And I agree, you're looking for a timeline there, you don't really want to say, 2 months, 6 months, a year. Yeah. I don't know how I would answer that, but luckily she's got age on her side. So,
but she does have pretty significant loss already. All right, here's something that is going to sound complicated, and we're going to make it simple. We're going to make it, I hate to say, ridiculously simple. He's an 82-year-old male who comes in for a pressure check. Now, he had complaints of foreign body sensations, some ocular pain or redness that had started about 2 weeks earlier. Now, and I think that was in his left eye. Now, history, he has glaucoma in both eyes, but his left eye was pretty severe at his last follow-up. His last follow-up was in 2018 when he had been lost to follow-up. Now, Medical history, he had diabetes. He had some mild diabetic retinopathy at his last follow-up as well. He was also using latanoprost. So now he comes in, he's got some ocular pain in his left eye for about 2 weeks. He's not seeing well. He had very severe glaucoma to begin with, a bit of diabetic retinopathy, and had been lost for follow-up for about a year and a half. So now he's 20/25 in the right eye, no light perception in the left. Cornea is normal in the right eye. There's diffuse epitheliopathy, microcystic edema in the left eye. So it should be left eye. Iris had diffuse neovascularization of the pupil margin in the left eye. Anterior chamber was deep and quiet in the right eye. He had about a grade 1 hyphema with red blood cells circulating in the anterior chamber. He had a posterior chamber IOL in the right eye. I had a hard time seeing in the left eye because of the cornea and the blood. His pressure is 23/62. Putting a gonio on, I could see neovascularization in the angle. I can see synechia, and I saw some hyphema in the left eye. Greg, is there anything you want to know here, or are you okay for making a diagnosis?
How old was the patient, Joe? Remind me.
82 years old.
Yeah. And the neovascularization was down into the angle, huh?
There was something that, now here is dense corneal clouding from edema.
Yep.
Here is our hyphema, and there was a nice reddish hue around the pupil margin. So he had neovascularization of the iris. He had neovascularization of the angle. Now, when I look with a gonial lens, there's blood down there and there's synechia down there.
He's NLP. Did he lose his vision suddenly at one time?
He didn't say suddenly, but
Okay.
he said he had not been seen for a while in his left eye.
Okay.
So that brings me to polling question number 5. Greg, does this look familiar to you?
That looks like Nashville.
That is Nashville. It's actually the view from a hotel window. So which medication is not necessary in neovascular glaucoma? Is it atropine, the beta blockers, steroids, miotics, carbonic anhydrase inhibitors, or I don't know. That's why I'm here, to learn. Which is not necessary? A lot of choices, so I think we'll have a very wide spread here.
Let me see. Questions are good. And they're slowly rolling in here with the answers. Good.
Mm-hmm. So what medicine do we not use in a case like this?
Uh-oh, I think I hear Mason.
Yep. Dog bark in the background.
Things are slowing down, I think.
All right.
Let me share the results. And looks like miotics won just by well, you got miotics and atropine. So you kind of got them opposite there. So you got miotics by a percentage.
Okay. And miotics is actually it. That's the answer, because if we're myotis, we're going to tear some vessels. We're going to increase blood aqueous barrier breakdown a little bit more. And we're probably going to have a little bit more hyphema. And that's when we don't really need to use. Now, do we have to use all of them? Now, any aqueous suppressants are very good. But what people forget and people don't go for, and this is actually very important, a steroid. A steroid is going to help reduce inflammation, stabilize some vascular membranes, and reduce bleeding a little bit. And what seems antithetical to what we're dealing with, which is a closed angle situation, atropine is actually a very important medicine. You need to put the eye at rest. You need to also stabilize the vascular membranes, reduce iris friction, reduce bleeding. Steroids, atropine, all very important. Aqueous suppressants, all very important. Prostaglandin analogs, meh. You're not going to really hurt the patient using it. You're not going to really help the patient either. So I would say myopics are the ones we don't really need. Everything else is actually fairly well informed. So what happens in neovascular glaucoma? Something precipitates retinal hypoxia. Artery occlusions, not common. I've only seen one artery occlusion in my entire career that went neovascular. Vein occlusions, however, are very big cause. Ocular ischemic syndrome, carotid artery disease, diabetes. These are all very common causes of the retinal hypoxia. And when we have retinal hypoxia, these 6 polypeptide proteins called VEGF are going to be released because the eye wants to reperfuse with new blood vessels. Now, in the back of the eye, after say a vein occlusion, a central vein occlusion, this VEGF needs healthy endothelial cells from viable capillaries from which to germinate new blood vessels. In these retinal hypoxic conditions, there's really nothing back there that's going to work. So what happens is the VEGF will diffuse forward through the vitreous, and the first place that they come into contact with viable capillaries is the posterior iris. So blood vessels will grow across the posterior iris through the pupil margin across the anterior iris into the angle. Also, you can have neovascularization just growing in the angle. Now, it's not so much the blood vessels, but with it comes this connective tissue fibrotic scaffolding. And that is what's supporting the blood vessels. And that fibrotic scaffolding will actually take the cornea, take the iris, and zipper them shut in what is a synechial angle closure. Now, the pupil's not blocked. It's a secondary angle closure without pupil block. Now, for those of you who have seen neovascular glaucoma, you know it's an ugly situation. There's often pain. There's underlying precipitating retinal disease. The vision is very poor. Pressures are often very, very high. And it can be an uncomfortable situation. And I agree with that. It is one of the worst acute glaucomas that we're ever going to encounter. That being said, diagnosis can be straightforward and management is actually pretty standardized. Here's what they need. Just follow this recipe. Atropine 1% twice a day. Yes, it's necessary. A steroid such as Predforte 4 times a day. Yes, it's necessary. Aqueous suppressants based upon how high the pressure is and what the patient's medical history is. Beta blockers, alpha-2 adrenergic agonists, carbonic anhydrase inhibitors topically, carbonic anhydrase inhibitors orally. These are all acceptable. PGAs, they're not really going to help. Myotics can worsen things a little bit. Stay away from that. Rho kinase inhibitors, it's a closed angle situation. I don't really think we're going to have much effect there. Ultimately, what these patients are going to undergo is they're referred to a retinal specialist, and it is not an emergency. In most cases, not an emergency situation, especially a patient who's got such poor vision. It's no light perception. It's not like we can make it worse and go to no light perception -2. That's not going to happen. These are people who are often going to undergo anti-VEGF injections because that's what people are doing today. And the regression of the vessels is rather remarkable. I mean, you can cause regression in a day. The only problem is the precipitating hypoxic condition has to be addressed as well, because if it isn't, once the 6 to 8 weeks progress and the effect of the anti-VEGF, be it Eylea or whatever that is used, Avastin, it loses its efficacy. It all comes back. So ultimately, they're going to need probably a pan-retinal photocoagulation where they barbecue the fundus and they shut down the hypoxia, reduce the oxygen demand. And these are the steps that they generally follow. Greg, do you have any comments here or your experiences here?
No, I agree with everything you have there. My comment would be to echo is that I wouldn't have believed it if I would have witnessed it myself, is Patient came in with pretty much florid, brown iris, blood vessels all over it, hyphema, you know, the neovascular glaucoma and gonioscopy. They went over, sent them to the retinologist. They injected the anti-VEGF, and I like to teach and so on and so forth. So I told the patient, "Come on back. I want to see what this looks like the next day." And I'm like, "The blood vessels are all gone from the anterior chamber," and then that gives them the ability to go in and do that PRP. The other comment that I would say is, the reason why you don't really see, much neovascular glaucoma with a CRAO, central retinal artery occlusion, is the artery is what's bringing blood into the eye, and dead is dead, right? So if you got a CRAO, you're not going to really have much blood coming in to allow the VEGF to formulate. Where when you have a vein occlusion, things are just kind of constipated, right? The blood's trying to get in, it just can't get out. Now you set yourself up for a hypoxic. So that's why your CRVOs or your vein occlusions are the ones that typically form the neovascular glaucoma. Now, the one, and I have seen artery occlusions, but they were probably partial, right? So they were probably hanging on, getting a little perfusion. Dead wasn't dead there, and they were able to form some VEGF that allows it. So it's all about understanding the mechanism of action there.
Yeah, the diagnosis is very straightforward, and once you follow this, I hate to say it, cookbook, it's actually fairly easy to manage. What did I do with this patient? I used the atropine, I used the pred. I didn't use Diamox. I used aqueous suppressants. I'm thinking maybe a Combigan. I don't know if I used anything else. Refer the patient out to a retinal specialist. Now, patient went about 2 weeks later, which was certainly fine. At that point, he had no pain. He was very comfortable. The cornea had cleared. The hemorrhage had largely dissipated. The retinal specialist was able to see into the eye, which I could not 2 weeks earlier. Saw there was evidence of an old central retinal vein occlusion, and did the anti-VEGF injection followed by PRP. Very straightforward. It seems frightening, but you follow this, and please don't forget the cycloplegic and steroid, and that is the optimal management for neovascular glaucoma.
I would say that the follow-up would be to go back to like when our attendee tonight asked, what's the long-term follow-up? What's the maintenance of this? I follow quite a few of these. I'm not sure why the docs in the area don't want to follow these. I get a lot of them. They're the easiest thing to follow. The eye's blind. What am I, like Joe said, where are you worried about getting them to NLP -2? The key here is keeping them comfortable. And I think the idea here when you're asking is most of these people, as they go through this cookbook and this recipe that Joe has put out there, and it's a great recipe, is that the patient is probably in about a 4-month period. If they did have a CRVO, they went through the PRP, they went through that whole mechanism that Joe was going through, that in probably in about 4 months, you're probably going to be down to 1 or 2 drops of pred. You're probably going to be using a drop of atropine and as a maintenance on these patients. And really, you're just trying to keep that cornea from breaking down. If you had a pressure of 40, I would be okay with that as long as the patient wasn't in pain. So the 2 things I would look for when the patients come back: are you having any pain? No. How's the cornea look? Is the cornea breaking down? If the cornea is becoming edematous, we know we're not low enough. So the long term, these are pretty easy. Atropine, pred, keep the patient comfortable, and making sure that that cornea stays clear, because that's where the pain can come from.
Yeah, and that goes back to something that we don't think about, and it's, I think, worth a mention. Do we treat a blind eye? And the answer is yes. But there's no invasive surgery for a blind eye, and there's no multiple medicines for a blind eye. I mean, you can have less invasive procedures such as cyclophotocoagulation from the outside, photoablation from the outside. That can be done. You can use a drop of steroid and a drop of a cycloplegic, ad infinitum. These are things that can be done. But as the pressure goes up 40s, 50s, 60s, eventually in chronic disease, the sodium potassium pumps will shut down. They shut down, the cornea becomes edematous. Corneal nerves are disturbed. Microcystic edema forms. Microcysts coalesce into macrocyst or bullei. They rupture, very painful. Right? It's pain, that's where pain comes from. Eventually, those corneal nerves will deaden, you become neurotrophic, the eye doesn't wet, and what will happen is there'll be cicatrization, vascularization, and the cornea will opacify. So our goal is pain relief and cosmesis. If possible, keep the eye and keep it looking like a normal eye. All right, Greg, that brings me to a case as good as it gets. He's a 63-year-old male who knows he has glaucoma, but never followed through with treatment because he had poor access to care in the Caribbean, where he lived at the time. Now he lives here. His pressure is 43 in the right eye, 60 in the left. His angles are opened by gonioscopy. He's got hand motion vision in the right eye, 20/40 vision in the left eye, with a small temporal island of vision in the left eye. This is how he looks. And I don't think we have to go into the isn't rule or anything of that sort here, Greg. There's not much to say. He's got end stage cupping in each eye of exceeding 95%.
Joe, go back. It might be just kind of just to kind of highlight though in that right eye, you know, it looks pale, but we always say glaucoma doesn't cause pallor, and it doesn't. You're looking at the scleral canal there. That's why that nerve looks, there's no neuroretinal rim. We all, you know, it gets a little confusing when you do have neuroretinal rim and then and it's pale. That's when we say, okay, glaucoma doesn't cause a glaucoma is pallor, you know, it doesn't cause pallor. This nerve looks pale, this right eye, just because there's just no neuroretinal rim.
Mm-hmm. And he also had a history of retinal attachment in that eye as well. And here is the visual field in the left eye, which is his seeing eye, which is a pressure of 60, and this is a 10-degree field. This is a 10-2 field. So going back, 63 years old, pressure 43 and 60, hand motion 20/40. We see the nerves and we see the field. So I think that brings me to polling question number 6. I did take this picture. Greg, do you recognize where we are here?
It's one of your favorite cities there.
Quebec City.
Quebec City. The incline known as the
Funicular. So which approach is best for this patient? Medicines, trabeculoplasty, real glaucoma surgery, or I don't know. That's why I'm here to learn. See what people think is the best for this patient. And they're rolling in nicely.
Yeah, give it a 1 or 2 more to roll in here. This is part of that live and interactive. So if you guys can weigh in so we can show that we're interacting with the audience, please do that.
I think we might be about good here, Greg. So 15% say medicines, 27% say laser, 41% say real glaucoma surgery, such as a trab or a tube, and 17% aren't sure. I don't know. That's why I'm here to learn. Well, actually, can you put those results back up again, Greg? I'm sorry. I shouldn't. You can show those again.
Yeah, okay. They're shared right now. You don't see them? Did you?
Okay.
Did you got them?
Okay. No. Well, let's
Here,
look at the
I'll
options.
reshare them here. I'll reshare.
Okay. No worries.
You got them now?
Yeah. Let's look at the options. I'm gonna jump on trabeculoplasty. Trabeculoplasty is about as good as a medicine. You know, one bottle of medicine. It has its efficacy. It's a very good primary therapy, I think, for a number of patients who have mild to moderate disease, but this is fairly substantial. So it comes down, do we do a real glaucoma surgery or we do medicines? Now, I can tell you this is exactly the kind of patient that a glaucoma surgeon doesn't want to do surgery on. And I was presenting this, and there was a glaucoma surgeon in the audience, and he came up afterwards and said, this is exactly the kind of person I don't want to do surgery on. He's 20/40 going in, he's 24/100 coming out. The risk of losing fixation through a complication or even no complications for unexplained central loss does occur, and the risk is greater with the severity of the disease. Greg, you chuckled. You share with me, what were your thoughts here?
Yeah, that was, and that's why we do these. The majority, rolled in there, real glaucoma surgeon. My chuckle was, yes, me too, because I don't want to see this patient, but can you find a surgeon that's going to do, real glaucoma surgery on that? And they're going to beg you to try and do everything you can to manage this patient medically.
Mm-hmm. So medically, medicines may not be the surest, but they tend to be the safest in a situation like this, because the risk of a snuff out where they lose central acuity can be as high as about 13%, depending on the study that we look at after trabeculectomy. And with the more severe disease, the more likely they can have this snuff out. So my approach was do what's safest, and I started using medicines over a period of time. Ultimately, he ended up on a fixed combination of timolol and bromonidine, COSA, a topical carbonic anhydrase inhibitor, and a prostaglandin analog, all in his left eye. Now, I used a prostaglandin in his right eye just to keep the pressure temporized somewhat. And I guess to everybody's surprise, the pressure came down in his seeing eye to about 10 to 13, which one may not expect. Now, a patient whose pressure is 60, what is your target pressure? Well, you think your target pressure should be around probably 15, but honestly, anything under 60 is going to find time. So what's better than 60? 50. What's better than 50? 40. Any pressure reduction will buy some time. I wasn't anticipating a low teen, but we did get there. I don't recall what his pachymetry was. And he was a really good glaucoma patient. He never missed appointments. If he was going to miss an appointment, he actually would call and let me know personally. And one day I stopped the exam. I said, Doug, how you doing? I just asked how you are. He said, I'm thankful for all that I have. I'm thankful things are as good as they are. He said, my house is pretty well blind proof, and I'm able to do everything that I want to do. And he could read the paper and he could watch TV, and he was really very, very happy with that now. So what happened to him over time? This is one visual field. Here's another visual field several years later, couple years later, couple years later. How would you assess these 10-degree fields, Greg?
Looking pretty stable.
Yeah. So we go over the course of probably 7 years or so with this pressure reduction, and he's very stable. And I think that's one of the most important things to understand about advanced disease. Patients with advanced glaucoma are not necessarily consigned to blindness. If we can get a significant pressure reduction, if we can get it rapidly, and we can keep the pressure reduction by any means, laser surgery or medicine, these patients can actually do very well. And I have developed a lot of experience or accumulated a lot of experience with these advanced diseases. I will tell you right now is this is all true. If we get the pressure down, they can maintain their vision very well. He was doing fantastic. Everything was great. 7 years later, he is still as functional as ever. Now, he did have some worsening of his vision in his left eye. He dropped down to about 2200. And, he was not litigious. His response was, we had a good run, Joe. I'm happy. But the question is it cataract or glaucoma? So I take a look and we make a comparison of 8 years. And, why is his vision decreasing in 2200? Did he slip in glaucoma? No, his cataract is getting worse. Now comes the challenge, which is getting him cataract surgery. And this was actually a fairly significant challenge because nobody wanted to do cataract surgery on him. What are your thoughts on this, Greg? Do we let him, be blind to 2200, or do we actually try to go ahead with cataract surgery? What are your thoughts?
Yeah, 2,200, you're getting to the point, yeah, where you gotta, in a sense, take the risk. 2,400, it's also, the patient has to be involved and has to understand that, this could be, a bad outcome. But, the nice thing with cataract surgery, topical, um, quick surgery, not getting a big pressure spike, there's things that they could do at the time of surgery. Obviously, a skilled surgeon, and you have to make sure that that your patient knows here, the harder that lens gets, meaning denser, the more FAAO energy that has to go in to take it out. So we don't want it to get, if he's ever going to pull the trigger, we don't want it to become rock hard, because now that becomes more of an issue. So
Indeed, all very important points. And I was able to find a surgeon who agreed to do it, but he said, I want you to tell the patient that he can lose all of his vision. And I did. The patient went ahead. He understood, and he ended up with 20/70 vision, 20/50 at near. And one day post-op, he is quote unquote seeing beautifully at 21/50. Now, what was the final outcome? Sometime later, I went to my office at the university, and there's a little red light flashing on my phone. Telling me I had voicemail. I listened to it, and it was Doug's sister. She should always, I knew her because she would drop him off and pick him up from his appointments. And she asked me to call her, and I just had that feeling. So when I called, she told me that he had passed away. He had passed away of natural causes, and he passed away after 8, or I should say, close to 9 or 10 years of that severity of glaucoma, maintaining his functionality the entire time. So what I want to stress here is an advanced disease, and never practice beyond your comfort level. But patients with even advanced disease at time of diagnosis can do well if they have a significant pressure reduction. We keep the pressure reduction, and it doesn't matter how we get there. Greg, are any questions rolling in? So I think we're almost to the end here.
no, the questions were rolling in, and they kind of dried up or slowed down. So we're good.
Greg, is there anything else you want to add here on this case, or anything else that we talked about to kind of start rounding this off?
Nothing that I have at this point.
Okay. Are we about at our time? Have we exhausted our time here, Greg?
Well, we started at 7:05, so let's do 7 minutes, Joe, to kind of stay within cope. It's 8:38.
I'm going to jump
so-
ahead to something that I think is kind of interesting for me. Okay, Greg, I'm going to ask you, how will you handle these? And don't worry, it's not the too much. 38-year-old female referred for glaucoma evaluation after failing a LASIK screening because she had very thin corneas, and also she had an unusual looking appearance to her nerve. Now, she told me she'd been treated since her mid-20s for glaucoma, open-angle glaucoma with a beta blocker. Now, off of medicines, her pressure is in the mid-teens, upper teens, I should say, 17, 18, maybe 19, with very thin corneas. And here's what she looked like with her fields. And Greg, what are your thoughts here? What is your approach here?
Well, I mean, right off the bat, I just want to say they're anomalous. In a sense, they're tilted, they're obliquely inserted. You have RPE, crescents, you have some atrophy. Looking at the nerve fiber layer, it doesn't look terrible based on what I'm seeing here. The visual field defect down here is kind of neat. Is that a temporal? Is that what you're showing? A temporal defect? Is it?
No, this is a nasal defect.
Okay, a little nasal defect. Okay, so, but it looks like it could be from the atrophy that's around the optic nerve. So obviously those fields don't match what you would think if that was cupping. So
exactly, and in all the rules that we have, disc analysis really can't be applied when you have a congenitally anomalous nerve to begin with. And Greg, I don't know if I have a good name for this. There's oblique rotation, there's oblique insertion. It doesn't meet my criteria for a true tilted disc syndrome. And the problem is these type of nerves, if you look at anything in the literature, they all get lumped together. I don't think they're all necessarily the same. But Greg, how would you approach this case?
Well, if it was the first time I'm seeing them, I'd say to the patient, I'm not sure if you really need to be treated. At some point, we can consider discontinuing. We can stop it now, but if we do that, we want to watch them closely. We can watch them closely, and then consider pulling the treatment. But I'm not sure if this patient really needs to be on, a beta blocker. I think is what you said they're on. So I certainly wouldn't have a problem considering having that discussion. Here's the key that we have to, I guess, go by is that there's lots of optic neuropathies out there. And the one that you treat whenever it's due to pressure is glaucoma. So you don't always, this is definitely an optic neuropathy. It's an optic nerve issue, but I don't think it's glaucoma. So why are they on a glaucoma med?
Well, I think the patient is on a glaucoma, and let's talk about this. She's put on initially at age 25. Greg, how often do you see a 25-year-old primary open-angle glaucoma patient?
Yeah, and that happens to me a lot, and that's good. That could be a good way for me to answer it is I'll walk into the room and the patient's there, they're 32 years old, say white female, and they're like, I'm here for a primary open-angle glaucoma eval. They'll say primary open-angle glaucoma eval, and I'll go, I'm going to tell you right now, I don't think you have it. But, I'm going to do the workup because to answer your question, I don't see a lot of 25-year-old primary open-angle glaucomas. Secondary, maybe, but primary, no.
So somebody looked at this at some point, saw what would be CD ratio, probably a 0.8 in the right eye, a small nasal defect, and ergo, it must be glaucoma. But, Greg, you're right. This is an anomalous nerve, and congenital abnormalities can give visual field loss. So we actually had discussions now on medicine. Her pressure was probably about 15. Off of medicine, her pressure was about 17 or 18. So the beta blocker wasn't doing a heck of a lot at that point. We had a discussion. We agreed to discontinue and follow her. And what had happened is I followed her for about 11 years. Now she's nearly 50, and she developed some field change after about 11 years. What happened? Was this a glaucoma that was missed? The answer is no. This is a person who had anomalous nerves, who 11 or 12 years later, with 19 pressures and 450 corneas, developed glaucoma. So then I put her on treatment. She came down to the 9 and 10th level. But this was about a dozen years where she did not use any therapy, and she is now doing fine today. Any thoughts here, Greg?
No. What's your double OMA? You can maybe explain that.
Yeah, she has glaucoma, and she also has what I call a congenital OMA, or what I now determine as a double OMA, glaucoma on top of a congenitally anomalous nerve. So I'm going to wrap this up real quick, Greg. So similar yet so different. 45-year-old Japanese female. I'm saying that because, as we know, it has been stated that normal tension glaucoma is more common in patients of Japanese descent. Referred me for a glaucoma evaluation from the local optometrist, who tried several medicines and saw no effect. Her pressure never exceeded the mid-teens, very average pachymetry, and looked like this. Now, does she not look somewhat similar to our previous patient?
Absolutely. And look at the nice wedge defects too that are showing up. The neurofiber layer dropout, kind of similar to where those nerves are.
But look at the field. Now, the more egregious looking nerve, I think, is the right one, and it has very little field loss. The left one has actually pretty extensive field loss. So the question becomes here, is this a progressive disease? Is it congenital in nature? Do we treat this patient? Do we observe this patient? Greg, how do you approach this?
And I think you answered it perfectly. When we talk about all these optic neuropathies, we talk about glaucoma has to be a progressive disease. So I definitely see changes and maybe damage or developmental issues to this optic nerve, but is it going to progress? If it progresses, then we treat it. I think I feel comfortable monitoring at this point.
See, I would feel comfortable monitoring this nerve, but these are 10-degree fields, and my approach is if I'm wrong and she loses fixation, that would be very deleterious. I will tell you that I did try different medicines, Greg. I did find a prostaglandin that actually significantly lowered her pressure. Probably a few significant pressure points. I followed her for about 2 years with field every 3 to 4 months, to get that information. In the course of 2 years, she never changed a bit. Now, I could argue that one, my treatment was successful, or two, this is congenital, would never have changed. I don't know. But mercifully, she was lost to follow. So I think that's about it, Craig. I think it's time for us to start bidding our adieu, land this plane on time. Hopefully everybody enjoyed our discussions and our light banter. Greg, why don't you take it over and start landing?
Absolutely. Checking here to make sure that there's no questions coming into the chat box, which there are not at this time. I would like to thank everyone for taking Glaucoma Gauntlet, managing the challenging cases. It was my pleasure to be a presenter tonight and be moderator. Vanessa was here as our co-administrator. Joe, wrap it up, and then I'll do some housekeeping.
Well, that's really pretty much it. We certainly enjoy providing education to our colleagues. We've always enjoyed doing this and have a great time. I think we're getting close to being at the end of this special time and this pandemic. So hopefully we'll be able to see you all in person in the near future in the live meetings. We do live meetings. We've had a lot of success with it. We're willing to do that. And we're also very happy to meet with you on Sunday nights or Tuesday nights or whatever nights we agree upon and spread this information. So with that, thank you very much for spending your time with us and trusting us with your education. And hopefully we're able to help people out.